Everyone. I'm Dr. Onkar Swami on behalf of Emcure Pharmaceuticals Limited. Welcome you all in this very interesting session of tenecteplase in management of acute ischemic stroke, insights from ACT study. We all know recently published ACT study has created a lot of buzz where this study compared directly tenecteplase with alteplase, and large sample size and pragmatic inclusion and exclusion criteria make it matching to the real world scenario. And to take this session forward, we have very iconic faculty tonight who will be discussing about ACT study and also implications of ACT study at real life scenario. We are very pleased and honored to welcome and invite our faculty for tonight. It gives me an immense pleasure to welcome and introduce Professor Bijoy Menonsen. He was a part of this study and a principal author and a principal investigator for this study. Sir has been a professor of Department of Neurosciences, Radiology and Community Health Sciences at University of Calgary, Alberta at Canada. He is a founder and a chief medical officer of Circle Neurovascular Inc. and founder and director of Peak Flow Technologies. His primary research interest is developing easy-to-use imaging tools that can aid in selecting patients in acute ischemic stroke for the revascularization therapy. Sir has been on an editorial board of a prestigious journal like Stroke, BNC, and Journal of Stroke. Sir has more than 588 publications on his credits and also a patent who makes a decision support tool for the stroke patient. Thank you very much, sir, being a part of this session. We really look forward for your invited lecture. Now, it gives me an immense pleasure to welcome our moderator for the evening, Professor Dr. M.V. Padma Srivastava, ma'am. Ma'am is a professor and head of the Department of Neurology and Chief Neurosciences Center at All India Institute of Medical Science, Delhi. Ma'am has been a recipient of the Padma Shri Award by President of India in 2016 and recipient of the prestigious Vimla Veermani Oration, Anchanta Lakshmipati Oration, and many orations. And ma'am has been a former president of Indian Stroke Association. She has been a national coordinator for SIT's new registry for thrombolysis for stroke data from India. Ma'am has more than 200 publications on her credit, and she has been a task force for the FIS Neurosciences Task Force, Department of Biotechnology, ICMR, and others. Ma'am has been instrumental for formulating the Indian Stroke Guidelines, which has been now endorsed by Indian Stroke Association. Ma'am, thank you very much being a part of this session and moderating this session as well. Now, I would like to welcome our esteemed faculty for tonight. It's my privilege and honor to welcome Professor Dr. Sailaja ma'am. Ma'am is a professor and head of the Department of Neurology at Sri Chitra Tirunal Institute of Medical Science and Technology at Trivandrum. Ma'am has been in charge of comprehensive stroke care program at same institute, and she has been a past president of Indian Stroke Association and honorary clinical professor of University of Lancashire, UK. She has been a member of task force group of a non-communicable disease divisions of ICMR. Ma'am has more than 80 publications on her credits and many book chapter. Thank you very much, ma'am, being a part of this session. I also invite our esteemed faculty, Dr. Subhash Kaul, sir. Sir is a senior consultant and neurologist at Krishna Institute of Medical Sciences at Secunderabad. Sir has been a faculty for prestigious Nizam's Institute of Medical Science, Hyderabad, and former professor and head of the Department of Neurology and also Dean of NIMS, Hyderabad. Sir has been a chairman of a KIMS Foundation and Research Center and more than 100 publications on his credit. Thank you very much, sir, being a part of this program. Sir has been always a mentor and guide to all of us at Emcure. I now welcome Dr. M. Pradeep, sir. Sir is a head of the Department of Neurology at KG Hospital and Postgraduate Medical Institute, Coimbatore in India, and also practicing senior consultant neurologist at Palakkad. Sir has been a postgraduate teacher for internal medicine and neurology at KG Hospital and Postgraduate Medical Institute of Coimbatore since 1998. Sir has been a coordinator in India for 2 years for Neurology Research Group of a World Federation Neurology. Sir has been always supporting to us and like a friend, philosopher, and guide to all of us at Emcure. Thank you very much, sir, being a part of this meeting. Now, I would like to welcome and introduce Dr. Arvind Sharma, sir. Sir has been a head of the Department of Neurology and senior consultant neurologist and stroke specialist and neurosonologist at Zydus Hospital, Ahmedabad. Sir has been a secretary of Indian Stroke Association and honorary associate professor of neurology at Bijoy Medical College and Civil Hospitals, Ahmedabad. Sir has been a president of Association of National Board of Accredited Institutes of Gujarat and a founder member and treasurer of Society of Neurology. Sir has many publications on his credit and received various awards like a Best Poster Award in 2009 at Seoul, Korea, and McKinney Award at American Society of Neurology in 2011 from USA. This would be our agenda. So with this short introduction, I would like to hand over this session to our moderator, to Professor Dr. M.V. Padma Srivastava, ma'am. Over to you, ma'am.
Thank you, Dr. Omkar, and thank you. It's an honor and pleasure to be on board in this 1 hour of, I guess, an amazing journey through the trajectory of connected place and its growing and burgeoning evidence. In fact, I would actually say it's probably our mistake that they've not been an updated CV sent across, but I'm sure all the CVs that were presented are actually old. I know Shaila's own accomplishments, which are much more than what has been presented out there. So all of you have been iconic, and it's a great honor to share the same space as you all. So because we have a limited time, and I want Bijoy to tell his experience. He's actually, you're really going to hear from the horse's mouth. He's hands-on, and he's going to lead us through this amazing, journey of showcasing or positioning tentative place in the management schedule of an acute ischemic stroke. And also, I guess, we will also have some chance to deliberate on Atmanirbhar Bharat, where actually I think India has been a showstopper in the runway of, the tentative place and its use in acute ischemic stroke. I will have some, interesting questions which are out of the box for you all, because you all are truly iconic, and I'm not going to ask you or deliberate upon things which are, again, run of the mill. So without much ado about furthering what is like really carrying coal to the Newcastle, if I'm going to talk about the usage of the newer thrombolytic drugs and how tentative place has come on board amongst, all of us have been using this, and especially in the COVID era. So I'm not going to talk about it. Just a couple of statements that Bijoy, you would know that, ever since that publication in 2017 in Lancet of Neurology, where, there's been this tectonic shift in kind of the non-communicable disorders taking over communicable disorders and catapulting the stroke up there. It is the number 1 cause of death and disability in the Northeastern states and into the number 5 in NCDs across the rest of the country. So, there's been a spotlight on stroke management, which is welcome change from what has been, say, a decade earlier. So in the last, I guess, I must say almost 1 decade, there's been a real emphasis even amongst the policymakers and implementers to get stroke outcome optimized, along with what always has been a domain of cardiovascular, diabetes, hypertension, and what have you. So I think it's amongst the big 5, stroke has really got its spotlight on. And that's been one of the things wherein in the entire stroke chain of survival, whether, while we are trying to prevent strokes happen. And while we're trying to rehabilitate them, strokes are happening. So when they happen, what needs to be done at all the, the delivery systems, whether it's primary, secondary, or tertiary. And so that part in India is gained a lot of momentum. And amongst the panelists, I can tell you that, almost all of them are in that with the think tank with the government of India and trying to get the policies and implementing. So it's a great show that we can have. And over to you, Bijoy. So once you deal with the nitty gritty of tentative place and how it's going to really come into the mainstream as the go-to drug for acute ischemic event, and then we can open up the entire flow for discussion. Over to you, Bijoy.
Thank you, Padma madam. Let me just try sharing my screen here. So I hope you can see my screen now, and can you hear me too?
Yes, we can. Yeah.
Okay. So I'll just put it on presentation mode now. So okay. So thank you, everyone. Thanks, Dr. Swami. Gives me great pleasure, as Dr. Padma was saying, to actually be with all of you, because I've known all of you for quite some time, and just feels very good being amongst friends. The session, as I think I also look forward to the discussion. So my role here would be to present the results of the phase 3 ACT trial on intravenous alteplase compared to tenecteplase in the context of the story of tenecteplase. And then I actually look forward to the discussion and to learn from all of you. So here's my funding, and this is specific to ACT. I was funded by CIHR, which is the Canadian equivalent of the NIH. And then we also had additional funding from the Heart and Stroke Foundation, the Alberta Sports Support Unit, which we're very proud of, because this trial was also a patient-centered and patient-engaged trial, and then Alberta Innovates. And so you all know the story of thrombolysis in acute stroke. Streptokinase, in fact, was discovered in 1930, so known urokinase in 1940, so even before the Great War. But it was only in the 1990s that the NINDS TPA trials happened that resulted in thrombolysis with alteplase becoming standard of care. In the interim, there has been, this increasing effort to find out other thrombolytic drugs that might actually be better. In the late the first decade of the 2000s, desmodipase was the flavor of the day, but the DS trials with desmodipase were not successful. Michael and I still remember, when I was just off my fellowship, we wrote the editorial for the DS3 trial, or the DS4 trial, and why it might have failed. But then the tenecteplase story, I must say, started with cardiology and with their trials with ASCEND-2, say, for example. However, in neurology, the first trials happened with Clark-Haley. So the first trials happened with Clark-Haley. It was around 2005 or 6. These were dose-finding studies. And then, interestingly, so I've been sort of involved in that story. When I was in Newcastle with Mark Parsons, that was when that initial dose-finding study with 2 doses, 0.1 milligram and 0.25 milligram tenecteplase, in comparison to alteplase, was happening. So it was a small study, again, phase 2, 25 patients in each arm, that showed that tenecteplase might actually achieve better reperfusion rates than alteplase. Subsequently, Keith Muir started the ATTEST-1 study from Scotland, and that study again showed that tenecteplase at a dose of 0.25 milligram could be safer. We at Calgary, Sheila Coots led Tempo-1 study. This was in minor strokes, compared 0.1 to 0.25. It wasn't a direct comparison in the sense that this was mostly a safety study that led to the Tempo-2 study that's still going on. But the first year, 25 patients were with 0.1 and then 0.25. And we found that, 0.25 was slightly better reperfusion rates, had slightly higher risk of bleeding. And then subsequently, Bruce Campbell's Extend IATNK study was what, put the cat amongst the pigeons. This was a phase 2 study again, but was comparing tenecteplase to alteplase in endovascular patients, showing, interestingly, even for a clinical outcome, that tenecteplase potentially was better in these patients, and it was opening up more arteries. While this was all going on, we everyone else was also focused on improving processes with acute stroke. So we all know time is brain, but to actually implement it, to implement thrombolysis in all our patients has been a decades-long effort. Dr. Call, is, I think, intimately aware of the effort it takes to actually, make something like this work. And so the Emberson data was really important. This was in the Lancet. This was a meta-analysis of all the randomized control trials on alteplase versus placebo, or no drug. And if you see these forest plots here from that meta-analysis, you would see that there is benefit across all subgroups. For those who present early, those who present 3 to 4.5 hours, for the elderly, as well as the non-elderly, and across different stroke severities. And so these two stories were happening at the same time. We were focusing on improving door-to-needle times and our utilization of thrombolysis with alteplase, while at the same time, we're also trying to see whether we might actually achieve, be able to find out a better thrombolytic agent. And tenecteplase was an ideal agent. It was being used by the cardiologists for MI. It did have pharmacokinetic advantages. Tenecteplase had more fibrin specificity. It had more thrombolytic potency. And interestingly, the fibrinogen depletion that happens systemically was actually lower. Potentially, therefore, meaning that it might actually open up better arteries that are blocked. It may be safer than TPA, but more importantly, because it is given as a bolus in comparison to alteplase, which is given as a bolus and a 1 hour infusion, that it might actually then result in faster treatments. And so less errors in dosing, less use of infusion pumps, less need for IV access, more efficient intra and inter-hospital transfers. These were the potential advantages of tenecteplase. And so this question has become, after the endovascular thrombectomy trials, the seminal question in acute stroke, the next paradigm, something that, we all look forward to. So the phase 2 studies, and I mentioned Clark Haley here, as you can see, of Mark Parsons, and there's Keith. These are the 3 studies that were happening then. And so this was the individual patient level meta-analysis in these phase 2 studies, seemingly showing promising results with tenecteplase. But, for evidence to accrue, we do need phase 3 studies. And so that was the context of ACT. IV alteplase was the global standard care, but it did have its limitations, including the way it is administered, which might actually pose a risk to its pharmacokinetics and therefore efficacy. IV tenecteplase was available, had potentially better pharmacokinetics, and more importantly, it was actually very easy to administer, not to mention the cost factor. And we had phase 2 studies that were showing potential efficacy and safety of tenecteplase. The real-world effectiveness and safety remained uncertain, however. And so that is the context in which we ask this question in patients with acute ischemic stroke who were eligible for IV thrombolysis in routine care if tenecteplase at a dose of 0.25 milligram per kilogram, non-inferior to alteplase for 90-day functional outcome. This was assessed using the Rankin. Now, why did we choose the 0.25 dose? As I told you, from the dose finding studies, it did become clear that 0.1 milligram was not as good as 0.25 in terms of its efficacy. The bleeding rates were not substantially higher with 0.25. Interestingly, with 0.4, Clark Haley's dose finding studies suggested that 0.4 may actually be harmful. And then the Nordtest 1 Norwegian trial happened, which actually compared 0.4 to alteplase 0.9. And that was a neutral trial. But they did a subgroup analysis, which then subsequently led to the Nordtest 2 trial that was published recently that stopped early because 0.4 was harmful. But more importantly, we also had Bruce Campbell's 0.25 versus 0.4 Extend IATNK Part 2 study that showed that there was no additive advantage with 0.4 when compared to 0.25. In fact, they might actually be more harm. And so this is how we sort of, nailed down the 0.25 dose that we thought was appropriate. So this was the trial design. ACT was a large multi-center prospective randomized study. It was open label because, we didn't want to blind our patients and investigators. It's sort of impossible to blind in a acute workflow, but it did have the classic blinded endpoint assessment, which actually limits bias significantly. And so this was a probe design. Just to let you know, probe designs are the norm with acute stroke with the endovascular endovascular thrombectomy trials and most of the thrombolysis trials, including the IST3 trials. This was the standard. ACT was also unique in that we also wanted to collect data from our acute stroke registries. And in Canada, there are 2 of them that are operating in different provinces, quicker and optimized. We had 1:1 randomization, and I'll not talk about minimization. That's a statistical fact. It was Health Canada regulated. We actually borrowed from cardiology because we wanted to also sort of have, ease of administration and of TNK. And so we used a decile weight-based strata. There were 5 strata, 60 to 70, less than 60, 70 to 80, 80 to 90, and 90 kilos. And then this would be the dose of TNK that is administered. Remember, the dose is 0.25, which is half the cardiac dose. Who were eligible? All patients who would meet eligibility by the Canadian Stroke Best Practice recommendations. What are the CSBPR recommendations? They are very similar. I've actually gone through, what you guys do here. The American Heart Association stroke guidelines, the European guidelines, they're very similar, these guidelines. And so our practice very much resembles what you would do here. And so this is what we were testing. These are the patients who were getting enrolled. We did actually enroll patients within 4.5 hours because that is what the Canadian guidelines recommend. And it was a non-pediatric study. Patients were enrolled by deferred consent where we had approval. The outcomes, so the primary outcome was typical. It was a Rankin 0-1, but we did have lots of secondary outcomes, Rankin 0-2, return to baseline function. We did have economic outcomes. We were interested in knowing how many patients would need endovascular thrombectomy, length of stay, discharge disposition, and the key safety outcomes, including mortality and symptomatic ICH. And then the follow-up imaging, we got it in all our patients, and then that was assessed by the core lab in a blinded manner, and intracerebral hemorrhage was classified by the Heidelberg classification. So this was a very large study, 1,600 subjects, 1:1 randomization. How did we come up with this sample size and why? So let me explain what we were trying to achieve here. We wanted to show that tenecteplase is non-inferior to alteplase. What does that mean? Essentially, take off the statistical language. What it means is tenecteplase for the primary outcome of Rankin 0-1 and for the other outcomes, we think that tenecteplase is either similar or better. And then this is what we wanted to prove. And our case was that if it is similar or better than alteplase, because of its other obvious advantages, including ease of administration and cost advantages, we will actually switch to tenecteplase. And so that is why we do a non-inferiority trial. Remember, the risk of doing a superiority trial is that you do not know by how much the drug might be superior. And then you run this risk of not meeting a superiority threshold and therefore having a neutral trial, and that actually pushes the field backwards. And so this is very typical with cardiology, oncology, with these other fields where as treatment advances, we have to now do equivalence and non-inferiority trials to push the field forward. And so this was the idea. And with the non-inferiority margin of 5%, the sample size was 1,600. This is how we enrolled. We enrolled from 22 hospitals across Canada, as you can see from east to west. This is where I am. We had all our Canadian hospitals, comprehensive stroke centers. We also made efforts to actually have primary stroke centers, small, more rural hospitals who might actually refer patients, and we tried to enroll those subjects too. Remember, we were running this trial during the pandemic. We started late December 2019, and this is when the pandemic started. And so initially we were a bit slower, but as you can see, we actually ramped up enrollment very fast. So this was the fastest acute stroke trial that's sort of run ever, to our knowledge. We finished in 2 years, enrolling 1,600 patients. And so here's the consort. 1,600 patients using minimization, 816 to tenecteplase, 784 to alteplase. This was, as I mentioned, some patients could withdraw consent. This was a deferred consent trial. And so excluding those patients, we had 806 in the ITT population for tenecteplase, 771 for alteplase. There were per protocol violations, including some patients who were just a minutes or maybe half an hour beyond 4.5 hours, these were removed for per protocol analysis, and for a safety analysis it was as treated for those patients who received the drug in the right dose. There was only one crossover in the entire study. These are the baseline characteristics. As you would expect with a large randomized control trial, you expect to see similarities. And this is what we see with these two groups. Who were our patients? The median age was in the 70s, almost 50% were women. The NIHSS was around 9 to 10. This was very different from the NORTES trial. But the NIHSS of 9 to 10 for thrombolysis is what we see in real-world practice. And so this actually resembled real-world practice. Who were the occlusions? As you would see, they were around 25% anterior circulation LVOs. We did enroll around 7 to 8% from primary stroke centers. Most enrollments came from comprehensive stroke centers. The pandemic did contribute. If the pandemic was not there, I'm quite confident we would have bumped up these numbers. And then I would ask you to look at the door to needle times, around 36 minutes. I think, this is actually really fast. I would sort of discount a 6-minute to the pandemic because the trial was running during the pandemic. And then if you look at the onset to needle time, 128 minutes. So this was, an early comer trial, right? Like thrombolysis within 2 hours. Here are the primary results. These are what we call the rankings. And so here, the lighter ones, rankin 0, 1, these are good. And then 5 and 6 are not so good. 6 is death. And so if you look at altiplase and you look at tenecteplase and you see how they look exactly the same. If you look at the rankin 0-1, you would see, like a primary outcome, 36.9% assigned to tenecteplase versus 34.8% assigned to altiplase. The unadjusted risk difference was 2.1%. The 95% confidence interval ranged from minus 2.6 to 6.9. This minus 2.6 is significantly lower than the 5% non-inferiority threshold. Obviously, we were not powered for superiority. If we had done an 8,000 patient trial, then the 2% effect would have translated into superiority, but we did not. We did a 1,600 patient trial. I want to show you what non-inferiority means because in our field, sometimes, it's sort of difficult to grasp that concept. This is the treatment difference between tenecteplase and altiplase. That is tenecteplase minus altiplase. And so let's assume that this, is this line of 0. And so if the difference is in this direction, altiplase is better. Difference is in this direction, tenecteplase is better. This is the -5 non-inferiority margin. Now, what did we decide at sample size? We said, okay, tenecteplase and altiplase are likely to remain really same. Or maybe, tenecteplase around slightly better, 2% better. And we did a sample size estimation. But at the end of the trial, we would only be able to show non-inferiority if tenecteplase minus altiplase was the maximum that difference could go to was minus 0.3%. And then the 95% confidence interval would be minus 4.9, and we would meet non-inferiority. What does this mean? That I can't show non-inferiority in a contrived manner with a drug that is, inferior to altiplase statistically. I have to show that it is similar or it is better. And so what did we finally show? See, this is, it is similar, but this is what we showed, right? And so here's the minus 2.6. This is the plus 2.1% in favor of tenecteplase. And then this is the 3% non-inferiority margin. What is this 3% non-inferiority margin? It is the FDA's recommended very conservative 50% of the lower 95% margin of the altiplase versus placebo difference. And so the minus 2.6 was actually lower than the conservative 3% non-inferiority margin too, thus suggesting that non-inferiority was met robustly. These are the secondary endpoints. And I would like to point out, a few outcomes here. So if you look at the rankin 0-2, the direction is almost the same. Tenecteplase slightly better. If you look at endovascular thrombectomy, there was not much difference in utilization. Return to baseline functioning. How many patients returned to baseline function? Again, tenecteplase was more, not statistically different. The rest of the outcomes are almost similar. The safety endpoints, we want to know this, how safe is this drug? And you'll see that death, mortality, 15.3 and 15.4%. If you look at symptomatic ICH, almost the same, extracranial bleeding, almost the same, exactly the same. In fact, you look at the risk differences, there's no difference here. If you look at all these numbers, the groups are not different at all on safety outcomes. And then these are the subgroups. The way I would sort of, look at these forest plots these are pre-specified subgroups. What I would ask you to do is to look at the zero line here. The zero line is the neutral line. And then look at these plots here, these square dark boxes, and see where they lie. Do they lie on the neutral line and in one direction, or do they lie in the other direction? And you'll see when you draw this line, most of these actually lie in this direction. So they favor tenecteplase. Although we didn't find any statistical heterogeneity, which means that we didn't find any group differences, which means that this effect is consistent across all subgroups. Look at these Kaplan-Meier curves. This is the blue is the red is tenecteplase, the bluish green is alteplase. Exactly the same, right? Like virtually no difference at all. And then I show you some subgroups. The large vessel occlusion, after Bruce Campbell's study, there was some interest saying that tenecteplase might open up more arteries here. Although we were starting to see some differences, the difference was around 2 to 3% for tenecteplase. And the non-LVOs, again, almost the same. Elderly, so in the younger patients, again, you'd see some differences. But again, no statistical heterogeneity. But, my broad message is you can see that, tenecteplase is either better or similar, right? And then early comers, late comers. In fact, in the late comers, you start seeing some, tenecteplase could potentially be a little bit more better. But again, no statistical heterogeneity. And then this is very interesting. And we are going to do subgroup analysis published separately on this issue, because the primary stroke centers might actually be relevant to India. I'm underlining the word might. I'm a methodologist, so I don't want to look at tea leaves. But if you look at primary stroke centers, we only had around 100 patients, but tenecteplase seems to have, more of an effect, right? Is that a time effect? Is that a stroke severity effect? I'm not sure, but we'll do more analysis here. The per protocol analysis is very similar to ITT analysis. We did have some challenges that I mentioned, but what did we conclude? In the largest thrombolysis trial done, on this question, in the first phase 3 trial done on this question, we show that tenecteplase is non-inferior to alteplase. What does that mean? The ACT trial results, 1,600 subjects, as many subjects as the entire endovascular thrombectomy Hermes collaboration, which had 1,600 odd subjects from all the trials. That ACT provides a compelling rationale to support switching the standard of care for acute ischemic stroke from alteplase to tenecteplase at a dose of 0.25 milligram per kilogram body weight. ACT was unique. It was a large trial with pragmatic eligibility criteria. It had rapid randomization, tech-enabled data monitoring. So it is the trial of the future, which is why it was able to run so successfully during the pandemic. The methods paper, which I'm very proud of, is published. And then the main paper is in the Lancet. ACT was a collaborative effort, was a pan-Canadian effort. I want to thank our patients and thank our coordinators, including Carol Kenny, who was a force behind the trial. Thank you.
Amazing. I mean, I would say what an awesome presentation too. I think it can only come from someone who's actually done it. So thank you, Bijoy. It was truly, truly illuminating. So it does, of course, raise this bar tremendously, that 1,600 patients, and the kind of the time frame that you had and the rapidity, or the kind of the enrollment and completion during COVID time was phenomenal. So congratulations once again from I think the entire universe, if not the galaxy. From all of us out here for really, really that, cementing the evidence that we have for a better thrombolytic drug. So if I may open up some of the discussions, and if I may start with, Professor Shailja. See, we do have this, the use or the evidence for the use of tenecteplase in almost all aspects of an acute ischemic stroke, not just in terms of time frames, in terms of the subtypes, as well as, the severity of strokes and whatnot. It's just a growing field. So what is your take on now with this ACT published, and also the fact that we have now a real world experience between 3 and 4.5 hours? Do you think now it's time for getting approval even in India. The time frame of usage of tenecteplase to between 3 and 4.5 hours, because till now it is approved for less than 3 hours. So what is your take on that?
Thank you, Padma. Thanks, Dr. Bijoy. I completely echo what Dr. Padma has mentioned. Truly fabulous. I think the largest trial done in such a short time, that too acute trial. It's. I think, hats off to you. So to answer the question, I would say that especially recently, we know for the past few years, tenecteplase was definitely coming up as a equal efficacy. And we have started thinking about giving tenecteplase as equal to the alteplase. Currently, with this ACT study, it has definitely made a difference because the previous trials were all concentrating on looking at the recanalization rates and the large vessel occlusion group. So here, and we were thinking that that is a drug for the bridging group where you can rapidly give the bolus drug and take the patient to the cath lab. And with the Nordis trial, which was not very much, it was neutral. So there is not much of evidence in all severity of stroke. The important information we got from the ACT trial is that all the subgroup of the patients, whatever be the stroke severity, whether it be a patient with the sex, every aspect of it, even with the vessel occlusion also, we have shown that definitely there is no difference between alteplase and tenecteplase. So that is in fact giving all of us a confidence of giving the drug in the later time window of 3 to 4.5 hours, and that too in all the subgroups. As Padma has mentioned, I think it's time for us to think about to really start using tenecteplase in clinical practice, which we have already been doing, especially in the subgroup. As I told you, we were mostly using in the patients when we are nearing the time window, we don't want to waste with the infusion, or in situation you want to immediately take the patient to the cath lab, give the bolus and take the patient. Or when we are taking a patient from outside, they give the drug and bring the patient to us. So this definitely gives us more confidence. But one point, Padma, if I can ask to Bijoy, is with regard to you showed a small percentage of 2% of the patients who are having ICA with tandem occlusion group in that study. So do you think in those patients, we all know that larger the clot, we really do not know what is the role of 5-ATPA. Does the clot location or the burden has got any difference in the use of tenecteplase versus alteplase?
Yeah, thanks, Shailaja. So I did actually show you the LVO versus non-LVO forest plot and Rankin distributions, and there was a suggestion that maybe tenecteplase was potentially acting more with larger clots than alteplase. But we actually looked into this data in detail now, and this will actually be presented at the World Stroke Conference, hopefully. And at least my opinion is, when I look at that data, that yes, there might be some benefit, but I think it is actually almost the same, right? So which means that I would say that tenecteplase is the same, if not better, for large vessel occlusions, for medial vessel occlusions, across board, right? But I do not think we have conclusive evidence to show, the results from the phase 2 data that tenecteplase is better for large vessel occlusions. I think, the effect that we see overall persists with, the larger clots too.
Thank you, Bijoy. I think spoken like a true scientist. And thank you, Shailaja. So I'm sure then that you would also be a proponent to now get our guidelines to include tenecteplase up to 4.5 hours, because currently the guidelines don't say that for the Indian setting. Thank you so much. And now if I may come to you, Professor Pradeep. So you are the neurointerventionalist as well. You have gone into the realms where at least I was dreaming of and I couldn't, and I you're one of our iconic figures from India. So again, taking from the same point that in large vessels and with a push of tenectic place, you do have the published evidence that you may not even need interventions in some of the studies which have been published, of course. And as Bijoy said, we have not found the last answer yet. It's probably still a gray zone, and the jury is still out from what Bijoy says. But said that, in your experience, now you deal with the interventional group where you are getting the large vessels, the LVOs. What is your practice currently? So you would still, I mean, there is a lot of evidence which said that you need to bridge. So that is also has come out now from almost all the study groups that we have. So what is your go-to thrombolytic agent in your bridge for LVOs in your practice that you're doing now?
Okay. First of all, thanks for inviting me for this great event and wonderful talk by Dr. Bijoy. We're so happy to have you here, and a wonderful your research topic which you presented, which is useful for the whole world, you know. We have all been waiting for that. Thanks a lot for the excellent presentation. And regarding the question which was asked to me, see, honestly speaking, as Professor Shailaja has told, the answer is still not fully out as far as the large vessel occlusion is concerned. But what we face now is, regarding in India, especially in our part of the country, is the cost factor, again, coming to the point. You know, still, and with the extend IA study coming into our this thing, which is clearly shown that when you bridge with the tenective place, actually there is almost double the recanalization which is taking place. Almost 22% is the recanalization vis-a-vis 10% which you saw with tenective place. So that was the biggest thing which happened, actually, which were giving us this thing to use tenective place, even if you see a large vessel occlusion, because that study has really given us a larger impetus in giving it. So, and not only that, the cost factor also comes into play, you know. So with those two factors coming in, and we have found that in our practice also, when we give tenective place, incidentally, the amount of reperfusion which is happening before the procedure is definitely comparatively slightly better than compared to the altiplace. So definitely, even in a large vessel occlusion, definitely we do the bridging rather than directly going in for a thrombectomy. That is, our practice is not to go directly for a thrombectomy. And we now, the preferred agent which we use is with the evidence which we have, especially from the extend IA TNK study, which we use the tenective place, and then only we go in for the thrombectomy, either by thromboaspiration or thrombosection or by the Trevo retriever. But still, we find that the recanalization rate is better than which we saw with altiplace.
Right. So thank you so much. So your go-to drug is now tenectic place, especially when you're dealing with an LVO and you need to bridge. So yeah. I needed that answer from you. Thank you. Now, if I may come to you, Dr. Arvind. So, you know, you've been at the helm of affairs of the Indian Stroke Association, and, you know, we've had a lot of things going in the COVID era. And across the country, we've seen, and Bijoy would also probably agree with me in some aspects on that all of us prefer tenectic place. And I think into the bandwagon of the usage of this thrombolytic agent, and even in skeptics, had gone up for reasons more than one during the COVID era, simply because of the ease of administration, as well as the numerous limitations which were imposed in the COVID care and an acute ischemic stroke care. So there were two verticals on which tenectic place was very happily positioned as, again, for majority of us preferring this agent. So what would you say, what would you think that experience during the COVID times has it actually opened up the avenues and also a thinking and also made skeptics more tuned or more experienced and more believers in this thrombolytic drug to be in the arsenal that we have in an acute ischemic stroke, not as just as a kind of, okay, we would also have this, or something which is equal, if not more likely to be of relevance in the Indian context. What's your take on that?
Thank you, Dr. Padma. Thank you very much. And I'm really happy to be here, part of this esteemed panel, which we have with a lot of experience. And I congratulate Bijoy for the wonderful study which he has done and the way he presented. And the most important part in that study was the primary and the comprehensive stroke centers. As we see that most of our primary centers, many are using tenecteplase off-label, and they are coming to us, right? And we are seeing the results. So that primary center which you have involved is very encouraging for us, right? And it was a very good part which you have done in this study. And I agree to all the panelists which have told that this drug, I remember when I was part of DIAS 3 at Edmonton, at the time, Michael and you were doing the wake-up stroke study for tenecteplase, and I have used that tenecteplase at the time in 2009. Right, when Ashwak was also there. So experience was good at that time for wake up also, right? And so I will agree to all the part, but I have two questions, if Dr. Padma, if you let me ask, right? So the as you have seen, the tempo 1 has showed that from 0.1 to 0.25 is better, 0.4 to 0.25. Are you thinking of more dose adjustment in this study? After doing this study, you're going to come to somewhere slightly lower, or I don't know. I've gone through those detail in the study, and we asked our fellow also to present, and we're discussing this part. So that input I need from your side, how you see it. And definitely we're looking this as a more and more drug as a stroke neurologist in your armamentarium to administer with ease, and definitely in bridging. But even as this study proves that if there is a LVO or no LVO, this drug can be a part of within 4.5 hours. Do you think this can extend from 4.5 hours to 9 hours, or as the altiplase is being used till 9 hours for beyond, if we do the perfusion studies and further? So these are the two questions to you, Bijoy.
Thanks, Arvind. Always a pleasure talking to you. So I'll sort of go in reverse order and go with the extended time window questions first. I think when we were presenting the ACT results at the European Stroke Conference, the TWIST trial results from Norway was also being presented. This was the wake-up stroke trial comparing tenecteplase in wake-up patients with, like standard care, which would not be thrombolysis. And interestingly, so that was a I think 580, 570 sample size study. So aimed for 600, but had to stop a little bit earlier. And if you actually look at the ranking distribution, there was almost a 7% difference in favor of tenecteplase, but the trial unfortunately was underpowered. It also did not use imaging selection. There is the Timeless trial that's happening. We're looking forward to the results of that trial coming out next year, possibly at the International Stroke Conference. This is a trial testing tenecteplase versus standard care in patients who present beyond 4.5 hours. I'm quite confident that with time, hopefully with Timeless, that we would have a positive trial. But if you actually, even if Timeless are not positive, if you sort of combine that data with TWIST, then maybe you would actually start seeing results in the extended time window. I do not see any reason why thrombolysis with imaging selection, the same way that we did with endovascular thrombectomy, cannot be extended to say even 24 hours if we're able to use imaging selection. And so that's my opinion on extended time window thrombolysis. With regards to the large vessel occlusion bridging question, ACT, we didn't find the same results that Bruce found, right? Like we had almost around 500 or 600 patients with large vessel occlusion. We didn't actually find significantly more reperfusion with tenecteplase. In fact, the recanalization rates early, before EBT, were almost same, with what I would call, the reperfusion rate slightly better. So this is what we found in real world practice, right? And I think I would echo what Dr. Pradeep is saying, that I think, there is slightly more sort of, recanalization, but it's not as substantial as what Bruce found, which is doubling the rate, right? And this is what we find in ACT. But to me, the LVO question is very simple. It's actually a question of, what is easy to do. And so if I have a patient who's actually going to the cath lab, the easy thing to do is to administer a drug in 5 seconds and be done with, right? And so if I have a drug that's, does that, when in comparison to Altiplase, where I have to carry that infusion pump and put it in Dr. Pradeep's face while he's actually doing the procedure, that's complex, right? You don't want that. And so it's quite simple. At least now with Bruce's data and now with ACT, it is very clear that, if you have a choice, that choice of bridging should actually be tenecteplase, right? Shouldn't be Altiplase. And then I presume I forgot the last question.
No,
but
these were
the dose.
Dose.
Yeah. So, so as a pragmatist, I think, we should move to 0.25. I think this is the dose. You will now have a test 2 trial, which would come up. There's the Chinese trial that's happening. This is all centered on 0.25. So as a field, we'll move towards 0.25, right? However, Andrew and I are also a favor personalized medicine. We think that, lytics should fit the person. And so we will continue to do our research, trying to fine tune this sort of administration of lytics. Salaja is involved in some discussions that we're having. We will do that, but that will take some time. But, for now, I think, the field should actually move towards 0.25.
Thank you. Actually, now, Arvind, I have a question for you since you're with ISA. Now, do you think it's the time for ISA to change the guidelines to include tenecteplase into the mainstream, as well as, or what about the dosage? You have the DCGA, which says 0.2, and then we have this, and, the maximum being 20, and here we have 0.25 and maximum being 25. So you think at least ISA can take this forward and, be the torchbearer to also help change I know the national guidelines, we have tenecteplase in. So the last draft that we have done just a couple of months ago, which are to be released by the DGHS as well as the Ministry of Health, has tenecteplase in. So we should be changing even the ISA guidelines.
Thank you.
I'm sorry. I was going to ask you a question, Arvind. But would you be interested in studying these doses? If you are, then you should join us in this effort. So
so that is my point, which Dr. Padma is mentioning, right? And which is what the Indian settings we are seeing 0.2. Is the doses really the 0.2, 0.18, or this is the doses where we are looking at even for the...
It's a very interesting question. I think it is an important research question. We should my opinion is we should study that.
Absolutely. I think for 0.2, there has been at least the Indian experience, which has been published, which is an index journal, though it is more of an observational and it is not an RCT. So, but it's been a large group which has published this experience. And also prior to that, there has been a pharmacological study with 0.2. The group from SGPGI, Professor UK Mishra and all have been involved in that. So I think there is an evidence for 0.2. So hence, I think taking this and India was probably the first country to approve as a national guideline to use tenecteplase, and that comes, the toughest question which I've reserved for Professor Kaul. He knows that, so I'm coming to you, Professor Kaul. What do you think now? There is an elephant in the room, which essentially is a biosimilar. So there are a lot of the critiques as well as skeptics who would say that the studies that we have is essentially from Indian setting has been a biosimilar. And we now have a real world experience from India, huge amount of data, which is again a biosimilar. Now, do you think the time has come to even showcase that the biosimilar is the same, that we actually have a hands-on experience which showcases a biosimilar which is far more inexpensive and has been tried out, and put the critiques to to rest, or do you think there is further more area to be covered as far as the Indian experience and the Indian, because what we use is different, and that is our own drug. Okay, and that will bring me to the other important question, and for that I need you as well as Bijoy to answer, is why is the world still so fearful and also not so convinced in bringing this agent into the mainstream? There is still some kind of hesitancy, and if you look at the guidelines, wherein it was not even close to level 1, but it had approved 0.4 milligrams at per kg body weight and for tenitic place and for minor events. And then the response had come that it was better with the Bruce study of a large vessel. And then we have Mahesh KT study, which went on till 24 hours. And that's why there was a discussion on if you are able to get those sprints where we do have a core collateral mismatch and you have large amount of critically perfused jeopardized tissue, which is not dead, it is dying, so you can intervene. So in this kind of a scenario, why is the world still so skeptical in bringing this molecule when the cardiologists have gone forward and approved this? It's taken us 4 decades and counting to get into the world podium. So 2 questions. The first question for you about biosimilar, and the second for both of you to answer. You're muted.
Padma, thank you very much for asking me the difficult question, but you answered the difficult question yourself partly. You're a real friend. You gave the hint. I think biosimilar is what we have. So for us, tenecteplase means biosimilar. There is no debate about it. That is the one which we will have because we have had a discussion. So I think whatever studies we have done on the biosimilar, right? And that is our tenecteplase. That is the Indian tenecteplase. That's the one which we may even export, or probably may already been exporting. So I think there is whatever Indian data we have so far, it is on biosimilar. And I think I was telling tenecteplase company that we should have registries now. And registries are very, they are real world experience. And in the real world, we'll have alteplase also, and we'll have this biosimilar also. And I'm looking forward to that. I think they may have talked to you also for multicentric registry. I think you have one other things, and I think that will give us an answer. I think doing a randomized trial also is another answer, but that is more difficult. Whereas registry data is real world, and that is the way forward. Now, the other question which you have asked is, I'll partly answer it, and then Bijoy is the final authority, he'll answer that. I think the world, and by world mainly we mean USA, I think, if you allow me to say that, because we go by the guidelines of the American Stroke Association and grade 1 and grade 2. It is slowly but surely accepting it. And Europe and even UK guidelines also are slowly but surely accepting it. I mean, if you look at the guidelines of the last 10 years, from not mentioning it at all and eventually mentioning it in NOR test for minor strokes was a step forward. And why did it minor strokes? Because that was true, because in that data, most of the strokes were minor strokes. So therefore, they gave it a recommendation. They gave it a weak recommendation for the simple reason that this was only one study which was there. That's how their system goes. The more number of studies you have, the strength goes stronger. So I don't think they are that unfriendly. And then the guidelines suddenly picked up after the Extend trial came, after the Extend IA trial came. They in fact mention it that it may be better. That word is mentioned there in American guidelines that if you are doing mechanical thrombectomy, then this may be better than alteplase. That is a huge thing for Americans to say. But then it says the quality of evidence is little little low. And I think that the reason, and even in the UK guidelines, they're the same. It's a strong recommendation, but the quality of evidence is low. And the quality of evidence is low because the number of studies is low. I think with this study, which Bijoy has come with, it's a huge step forward. I'm sure this will be a major factor which will make the quality of evidence strong, because what they need is the number of patients, what they need is the number of studies. And as that goes up, I'm seeing no reason why it will not go forward. The only problem is, and Bijoy has explained that also nicely, is that we don't have a study which says clearly that it is superior. If we would say that, then the matter is, settled. Then there is no question about it. But I guess that is very difficult to say for the reason which Bijoy says. Even in anti-convulsant world also, they will never say this is better. There is also some political silence about it. So I think I give to Bijoy to answer this.
Thanks, Dr. Kaul. I actually agree with your comments. I don't think there is any bias. The issue is data. The more data you have, the more, the quality of data that you have.
Bijoy, I'll tell you. So why you say data, that Altiplase got approved after 665 or 672 cases. The NIMS trial didn't even cross 700 patients. And I think when you actually took in, even before your study, when you had to put in all the studies of tentative place, you certainly crossed 700. So I'll have to bring this forthwith that, the NIMS trial only had 600. And I think I don't know, I don't remember, Shailja, I don't know if you remember the exact number. It was certainly less than 700. So I understand. You see, 1995 is different from 2022. And I know the world has changed. We have now Bijoys in the world. At that time, we did not have. That was 95. But still, I think that to me, there's been, and I think it is your study, as Subhash says, is a huge driving force towards, more acceptance, and also to look up and, look at the data which is coming forward. I think that is important.
I do agree with you, but if you just look at the numbers before ACT was done, most of the data about tenecteplase came from the NORTES trial. The NORTES trial was 1,100 patients using 0.4 milligram per kilogram tenecteplase, with a median NIHSS in that trial that was close to 3. And with almost 15 to 20% mimics. So of the 1,600 patients that were available before ACT, 1,100 came from NORTES, which was using a dose of 0.4 in a patient population that was completely different from who we would treat. And this was the reason why the level of evidence was low. Because even Extend IIT-NK, 200 patients, right? The total number of patients was 200. And when we now compare this to what the cardiologists do, Ascend-2, which was the trial that actually established tenecteplase, was a 11,000 or 14,000 patient study.
Cardiac guys
and so
have
what, like the strength of evidence is the same, whether it is for medicine, like cardiology, or for neurology. The strength of evidence is based on our confidence around what the effect size is. That confidence is a game of numbers. And so we need to be able to do large studies to actually change practice. Even look at, endovascular thrombectomy. Let us imagine that we had 2 small trials of 200 patients. Would, our practice have changed? Vis-a-vis the fact that we actually had 7 trials, all in the same direction, and with the total sample size now reaching around 1,600, 1,700. And so this is what happens with strength of evidence. So before, ACT, I think, the majority of these patients are actually coming from Extend IIT-NK, which was in fact 200 patients. And then the TASTE trial, which was 75 patients, and a TEST-2, which was 100 patients, and TEMPO-1, which was 50 patients. This was it. And Tempo 1 was a minor stroke trial. So, the strength of evidence, obviously, I'm actually an evidence-based type. If I look at the evidence, I'll say, okay, no, this is not.
No,
as
strong. As I said again, I like the statement that you made, that confidence is in the game of numbers. So absolutely, totally agree with you on that. Again, in 95, when the NINS trial came in, it also included all subtypes of strokes. It also had, stroke mimics. It had all sorts of issues, but that was 1995. And before then, the slate was clean. There was nothing on board. So that was a huge game changer.
Right.
So that had its own stupendous importance. So, but then it is 3 decades, and then we have so much which has changed, including, I guess, our knowledge and understanding of how to garner the evidence to make it much more robust in all fields and across the spectrum. So I really like that statement that I think we should use this. Don't you think, Arvind? Confidence lies in the game of numbers. I'll use this and I'll quote you on that. So, and Ini, I think we are almost running out of time. I don't see many questions out there, but there was one question which was asked, whether we need to have an infusion or push. Now, the biggest, I think the advantage of tenecteplase place, it's a push. And that's the reason we had used in COVID. That's the reason we use it in our bridge. That's the reason we use it in clinical practice in general. You're avoiding the infusion, so it is a push. So apart from that, I don't see questions as such, but if I can take the final comments, starting again from Dr. Shailaja.
I think it was, first I would like to say it was a very good discussion. And few things which was very clear from thanks to Padma for really moderating very well, taking into account all the important challenging questions which we had with regard to tenecteplase. I would say definitely our practice is going to change. There is no doubt with this trial. As was told, numbers definitely makes more confidence, and we will be more confident in using the drug. Second is definitely with regard to the cost, especially when it comes to India, cost is still a factor. And third, with what Dr. Arvind has mentioned, especially in primary stroke centers, now definitely tenecteplase is going to be a drug where you don't have to wait for an infusion, and you can give the bolus, especially if there is a center you want to shift the patient to. And another confidence which we got is from all the subgroups which you have shown, Bijoy. You have covered all the spectrum of the subgroups in the study. That is actually the fantastic part of it, taking into account the vessel severity, whether it is a primary care center. So all those facts, which in fact, especially being a study which has been shown, it is almost like a real world evidence. So I think that is the biggest success of the trial, and best wishes for bringing out the new trials which you may have, as you told, taking up Arvind's question of dosing, and especially with regard to what I would like to also add that as Craig has shown from the Enchanted trial, maybe in the subgroup where the risk of bleed is going to be higher, maybe we may have a dose of 0.2 versus 0.25 versus 0.3. These may be the subgroups where we may have to see like a personalized kind of a treatment where we may have to use the treatment. Thank you.
And then I guess from and taking on from there, then we would actually need huge numbers because the differences in would be there, but that's great. There were a couple of questions, so I'll quickly answer them. That one is that yes, extended time window frames beyond 3 hours well, we probably now have real evidence still 4.5 hours. I think we don't see why we should not be thrombolizing up to 4.5 hours for tenecteplase as we do for alteplase. But beyond 4.5 hours, we'll have to cherry pick. And that cherry picking is based on the current data of how in an imaging criteria of picking up what we call as, not sine qua non, but somewhere close to this critically perfused tissue, which I would say dying brain, not dead. So, salvageable brain tissue, which is as individualistic as is your own fingerprint. So depending upon the co-collaterals, what you have, both MR and CT based techniques, you can pick them up and there is growing evidence of use. So, but otherwise not routinely. And posterior anterior circulations, as Dr. Shailja said, a lot of subtypes have been covered in a lot of studies, and we don't differentiate, except we will always look at the large vessel and small vessel, because we always do vessel imaging in on all our acute stroke patients. So when you are giving it, tenectic place can be given for posterior circulation as well. So these were the two questions which came in. So the next final take home, Dr. Pradeep.
Yeah, it was a wonderful discussion which has happened, and a lot of, I think the ISA would now think of increasing the time window from 3 to 4.5 hours for administration of tenectic place. That would be, that happens, there is another great leap as far as the stroke management is concerned. Now, regarding the biosimilar which was asked to Dr. Subhash Kaul, I think with this biosimilar, Dr. Bijoy, we have already have more than 30,000 thrombolysis in India till to date. 30,000. So it is a phenomenal number. And we are yet to come across very serious adverse effects. Of course, we had, but not to any great extent. So that is ultimately the proof of this thing is evidence which we have is a great number of patients we have treated since the approval in 2016, which we had. So that is one thing. And really speaking, head-to-head comparison between tenectic place and altiplace has happened already as with regards to myocardial infarction. Real head-to-head fight has gone, and ultimately the winner was tenectic place. It was shown to be as efficacious as altiplace, but with less bleeding tendencies. So that evidence is always, we are not talking about a new molecule. We are talking about already a molecule about which we know everything. Now finally, so with this, I want to tell you that in 1987, altiplace got approval for myocardial infarction. But when did it get approval for acute ischemic stroke? In 1996. Similarly, it was in the year 2000, tenectic place was given the myocardial infarction. So we are just waiting for the day when the US FDA approves it for stroke. Okay, thank you very much.
And Arvind.
Thank you. Thank you very much, Dr. Padma, for moderating the session. And thank you very much for bringing out this topic. And thank you, Dr. Bijoy, for this wonderful talk. And
change the guideline of ISA.
Wait a minute, I'm coming to it. When we talk about the primary stroke center, why I spoke to you, everyone sitting in this room or those who are listening, retiplase is a drug which is used in periphery. As I'm telling to Emcure also, right? And all the companies, retiplase is a drug which is used like anything in a peripheral center for treating acute stroke within 4.5 hours. So we can put this message that there is another drug which is approved, which have studies done. Retiplase, no studies is done, right? It is not approved. So why people are using it? So the drug which we have in our capacity, which has shown results, and as Dr. Pradeep has mentioned, that time is taken for some things. Like we were all waiting for the thrombectomy trials to get that. So the Bijoy, those statement that we are working on the similar direction is there, right? So it is not a day left that it's not there beyond the guidelines of Indian Stroke Association or American Stroke Association. It is not a big deal.
We'll start with Indian Stroke Association.
Yeah. So I have a question with Bijoy. It's the last comment, I agree. So Canadian Stroke Consortium, what is your plan to get it on board? Because it is not US FDA approved. Okay, there is some. So what is your take on it as Dr. Padma is requesting that? Can you please?
Yeah. So we are transitioning over to tenectic place, and the reason why we are transitioning and not directly switching is because the dose is 0.25 and the vial available is the cardiac dose, which is 0.5. So we want to do it safely. And so this is happening all over Canada. I think it's happening all over the world now. The fact like at least in the Canadian context, I can speak, we give off-label drugs, right? Like we give TPA in the 3 to 4.5 hour time window, which is off-label. We give off-label drugs all the time. And so we can actually give the drug. The regulatory approval, we're also sort of, working with industry to potentially sort of help them with that. That will come in time, I presume. But just from a practice perspective, it's changing. And at least, in Alberta, I can say that by around September, October, I think, we will be making that switch to connected blissful.
Excellent. And so the final comment now from Dr. Kaul before we close.
Padma, you have already emphasized the important points. I just wanted to remind everybody that, when TPA was approved in India, tissue plasminogen activator, there was no study done in India at that time. It was just based on the US study, NINDS study. And at that time, I was involved in that. So we really pushed, and then finally that was 2004 or 2005. And they approved it based on the data, the study was not done in India. Now, how this 0.2 has come is because this study was started in India. When Pradeep and all were giving tenecteplase, it was not approved anywhere in the world at that time. And and even the doses were not known. There was a controversy, should you give 0.1 or 0.2 or 0.4? We started with 0.1 actually. And at that time, I think in their good judgment, they thought, okay, 0.2 is okay. And because of that 0.2, this drug controller approved 0.2. But I think we have to lobby with the drug controller that a lot of land has shifted since then. So many studies have been done, and we can just lobby there with the help of Indian Stroke Association. And not only that, you yourself, Padma, you are the most powerful person in stroke right now. You are in All India Institute of Medical Sciences in New Delhi, close to the drug controller, so your contribution also will be very important.
You mean distance-wise? Kilometers.
Three past president of ISA. Past president of ISA are here. Yeah.
So you know what? I know Pradeep probably knows that when the DCGI gave approval, it gave a conditional approval that okay, you do it for 500 cases and then we will see it. For similar thing, we can ask for 4.5 hours. I think we have to work hard towards it. It will be done. I'm very
already
sure.
there.
I'm also very sure. So I think thanks to everybody, and Bijoy, it's been amazing, and I'm so glad that we could connect with you. And we see this star, which has actually become a complete, I should say, a Milky Way. Totally, you really grown into a gigantic, iconic figure in stroke. It's thank you so much, and God bless you, and thanks all of you. It's wonderful to connect. Each one of you are amazing champions. Each one of you is a stroke champion in this country, and God bless you all. And so, over back to you, Dr. Omkar. Yeah, thank you.
Thank you, ma'am. It was a really intellectual feast. We have more than 400 logins who are listening across the country about this program. Now I will invite my colleague Prashant for extending vote of thanks. Over to you, Prashant.
Thank you very much, Dr. Swami. So I take this opportunity to have the formal end to this wonderful scientific feast. And I'm sure that all 400 plus live audience must have enjoyed the same way. Professor Dr. Bijoy Menon, we really thank you for taking your personal time out because you are on personal trip here and on vacation. But thank you very much for really taking time out for this and enlightening all of us with real, your insights on ACT study and how we can take it forward in Indian context. Professor Dr. Padma Srivastava, yes, you have really taken the pain, and in our last minute request, you have accommodate a lot of question in last this moderation in last 4 or 5 days. So thank you very much, ma'am. Professor Dr. Shailaja ma'am, thank you very much for being with us on this evening. It was really wonderful to get your clinical perspectives, and really I'm sure that entire India doctors must have taken notes of this. Professor Dr. Kaul, really, we have seen you in the past, and you are a wonderful host for our no thrombosis event. And today, your clinical site has once again given new clinical perspectives. Thank you very much. Dr. Pradeep, yes, you are the person who has always guided us, and not only guided us with your clinical insights, but always pushing us to do more with Tenectis. And I'm sure that in future we will work more closely to take it forward. Finally, last but not the least, Dr. Arvind Sharma, your continuous guidance, mentoring to us, and giving opportunity to working closely with you as well as with ISA is really a great thing for us. We are very happy and thankful to you for being with us on this evening. Thanks a lot. I take this opportunity to thank all our delegates who are seeing it live as well as on YouTube. Over 500 plus doctors we have this evening, and thanks once again to one and all of you. Thank you very much.
Thank you.
Thank you.
Thank you.
Bijoy.
We can stop live streaming. Thank you very much, sir.